Hello, friends. I'm Professor Smita Jha, and I'm here to discuss health and disability in humanities. And under this caption, I'm going to discuss Introduction to Narrative Medicine Part 2, because under Part 1, I have already described the very nature and the core theories, principles of narrative medicine, also patient empowerment, narrative telltelling. Now, let us discuss narrative humility in detail. So, narrative humility, what is this? In healthcare, there has been much debate about the role of empathy in patient doctor communication and whether it can and should be taught to medical students. Narrative medicine has not found empathy to be a useful term and claims empathy to be a misguided assumption that one can enter into or know another's experience. In place of empathy, narrative medicine offers narrative humility, a framework first articulated by Dr. Sayanthani Das Gupta as a critical companion to narrative competence. Narrative humility shifts the focus from a clinician's skill in reading a patient to an ongoing commitment to self reflection and openness. Why is narrative humility? Why this is so important to discuss? Narrative humility acknowledges that our patients' stories are not objects that we can comprehend or master. Rather, they are dynamic entities that we can approach and engage with while simultaneously remaining open to their ambiguity and contradiction. Furthermore, it encompasses engaging in constant self evaluation and self critique of issues such as our own role in the story, our expectations of the story, our responsibilities to the story, and our identification with the story. How the story attracts or repels us because it reminds us of any number of personal stories. Thus, in health humanities, narrative humility is a stance where healthcare providers acknowledge that they can never fully master or completely understand a patient's lived experience. Well, the shift from empathy to narrative humility is very interesting. Taking an approach that is different from narrative humility, the philosopher Harry Carroll believes in privileging patients' voices and their perspective in arguing for the promotion of empathy. Let us explore a detailed account of Carroll's analysis of empathy and how it differs from narrative humility. In Phenomenology of Illness, Carroll offers a perspectival analysis that is a valuable tool for delineating the relationship between empathy and narrative humility. Carroll also develops a useful distinction between the objective body and the body as lived. In other words, the distinction between disease and illness. Carroll's proposal of adopting a second person phenomenological perspective in order to cultivate empathy appears promising. However, it also raises important unresolved questions about identity and affinity. While Carroll does not specifically delve into the literary technique or point of view, it aligns coherently with her first, second, and third person phenomenological perspectives. For Carroll, the first person perspectives is the body as lived. The body as lived is the experience of this objective body, the body as experienced by the person whose body it is. The first person perspective is where one's illness experience occurs. The experience of disease is embedded and changes because of the I. For this thought experiment, we might assume that there are two patients who share the same biological and objective manifestations of the same disease, like cancer. Yet, if patient A says, I have cancer, and patient B says, I have cancer, even though the cancer is the same, the experience and perhaps even the treatment will be different because I is not the same. Thus, according to Carroll, empathy occurs in the second person phenomenology of illness. This second person phenomenology involves perceiving aspects of what ill person experiences. Carroll offers the example of when one spouse becomes chronically ill, such that the other spouse become limited in what she can also do. Thus, the other spouse is also having an illness experience. Carol notes that the kind of illness experience between a spouse is different, but she suggests as well that health professionals adopt this second order perspective towards illness. This second order perspective, she argues, can be developed through phenomenology and more specifically a phenomenological toolkit. Carroll describes three components of the toolkit. First, bracketing the natural attitude towards illness, suspends the belief in the reality of an objective disease entity. Second, thematizing illness that focuses on attending to the cognitive, emotive, moral, and aesthetic aspects of a phenomenon. Third, taking the new understanding of illness emerging from these two steps and examining how it changes the ill person's being in the world. Carroll envisions the toolkit being used in workshops with health professionals and patients, and as one of the means to address the epistemic injustice that privileges the doctor's perspective over the patient's. I agree that the health professional should be receptive to the patient's illness experience, but I believe that narrative humility is a better approach to achieve this goal. In Carroll's example, while both partners have a shared illness experience, these experiences are not the same because the I is different. Problems arise when health professionals attempt to adopt a second order perspective of trying to understand a patient illness experience, which is nonetheless predicated and dependent on one's own first person perspective. In this second order phenomenological approach, how would one differentiate between true aspects of what a patient is feeling and aspects of what the clinician is feeling? Furthermore, the couple dynamic of living life together and being bound by a legal document does not apply to the patient doctor relationship. Patients and doctors are not couples. The relationship is inherently asymmetrical. Meanwhile, while helpful, the practices of the phenomenological toolkit do not answer questions about indifferentiation and projection of the self. Bracketing the natural attitude is helpful in allowing doctors to think more about the illness experience than the disease. But how does this translate into feeling and empathy? Thinking is still a cognitive and disembodied practice. Furthermore, Carroll cites elsewhere the disability paradox. Those without X condition overestimate the impact of X condition on the quality of life of those with X condition, as proof that there is not a correlation between well being and disease processes. This overestimation, however, can result not only from conflating disease and illness, as Carroll suggests, but also from not having first person experience of the patient's condition. Similarly, in thematizing, attending to the cognitive, emotive, moral, aesthetic aspects of a phenomenon, overestimation is a potential problem. As a forum for cultivating a second person phenomenological perspective, Carroll proposes a mixed workshop of patients and health professionals to thematize illness. In this workshop, Carroll writes that patient may thematize her illness primarily emotively, while a health professional will thematize it cognitively. While mixing such perspective would encourage a more dynamic, nuanced understanding of illness, I feel that such a workshop would fall short of cultivating a second order phenomenological or embodied approach if, on the one hand, patients are primarily using emotions, and on the other hand, if physicians are thinking about illness. Moreover, identifying patients strictly with emotions also risks trivializing their perspectives and verifying the institutional hierarchy that the workshop is intended to challenge. Consequent to all these aspects, Carroll offers a space for physicians to explore and use unnamed emotions triggered by visual and sensual samples to understand illness and how it changes a person's being in the world. However, The practitioner again runs the risk that emotions are triggered because of some resonance and relation between the samples and the self. In his hypothetical workshop, Carroll does write that a family member might thematize illness as an experience of empathy. This makes sense in that it is similar to Carol's example of the couple's shared illness experience. For health professionals, this appears to be more difficult due to the asymmetrical relationship. However, the problem with promoting empathy is that it depends on the self and the self's past memories, experiences, and intersectional identities. Empathy also depends on affinity. You might wonder then what the key difference is between empathy and narrative humility. Narrative humility is having the understanding that a patient's story belongs to him or her. While physicians can certainly co create and co construct a narrative with a patient, the difference between narrative humility and empathy revolves around control and power. Empathizing, a physician is controlling the degree, implicit or explicit, of emotional investment. But in narrative humility, the physician understands that they can never fully know the story of a patient. What is the reason behind this humility? Giving an account of one less by Judith Butler serves as a foundational text in the field of narrative medicine that provide the answer. Butler argues that there is an opacity of the self. If we cannot give an entire account of our own beginning, how can we expect the same from others? Carroll's solution to poor patient doctor relationship is for doctors to gain a new understanding of illness and privilege the patient's perspective through the phenomenological toolkit. Thus, physicians might have access to parts of the first person perspective or illness experience through first person reports, but physicians can never fully know the patient's reality because certain experiences are inexpressible and contain some manner of opacity. However, if physicians adopt narrative humility, recognizing their own opacity rather than employing a competency based means of gaining a second person phenomenological insight into the experience of illness, we might produce more reflective doctors who value the patient's perspective. Let us know the key principles of narrative humility. The first is acknowledgement of the unfamiliar, recognizing that every story contains elements, cultural, socio-economic, or personal, that remain foreign to the listener. Rejection of mastery, unlike competence, which implies a finish line or a set of mastered skills, humility suggests that the listener is always a guest in the patient's story. Then comes self evaluation, a constant awareness of one's own prejudices, expectation, and the frames through which they listen. Testimonial justice, valuing the patient as the primary authority of their own experience and reducing narrative privileging where medical data is valued over the patient's voice. Mutual witnessing, which say entering a relationship where both the patient and the provider are seen as a whole, complex individuals rather than just a case and a specialist. Why narrative humility matters. In clinical practice, narrative humility helps bridge the gap in communication, especially in fields like psychiatry, where biomedical authority can sometimes overshadow a patient's personal history. It encourages providers to use their imagination to enter a patient's suffering without totalizing or assuming they know exactly how the patient feels. In conjunction with narrative humility, the term cultural humility, as opposed to cultural competency or cultural sensitivity, is used to guide clinicians in serving the needs of diverse populations, further recognizing that they are not the sole experts of the patient story. They also make use of skills like close reading and empathetic witnessing to fully absorb what the patient conveys. Cultural competency and narrative humility. The term cultural competency suggests it is somewhat possible to become entirely competent about another's culture. Building off that narrative humility can be a guiding force in the work of narrative health and social justice. Narrative humility is also, in many ways, a response to Rita Sharon's term narrative competence. The idea that health and humanities teachers can train clinicians to be utterly competent in eliciting and interpreting patients' stories. Cultural humility and narrative humility, as a more socially just alternative to cultural competency, Trevelyan and Murray Gracia suggest cultural humility. Building off that narrative humility can be a guiding force in the work of narrative health social justice. Narrative humility suggests an engagement with the stories that acknowledges that stories are not objects we can comprehend or ever become entirely 100% competent, particularly when those stories are oral interchanges with real live people on the other end. Taking a position of narrative humility means understanding that stories are relationships we can approach and engage with while simultaneously remaining open to their ambiguity and contradiction. While engaging in constant self evaluation and self critique about issues such as our own role in the story as listeners, our expectations of the story, our responsibilities to the story, and our ownership of the story. Also, by focusing on narrative rather than cultural humility, we recognize that this is a perspective we take with every story we engage with, and not just when one of those with other people walks into our office. Narrative humility, thus, means understanding that stories are not merely receptacles of facts, but that every story holds some elements of the unknowable. It simultaneously reminds us that there are larger socio-political power structure that marginalize certain sort of stories and privilege others. Furthermore, narrative humility suggests an inward orientation, requiring not only that we learn about others, but that we begin by learning about ourselves, how our past cadre of life stories has built our prejudices and preferences, and how, by the very act of listening, we ourselves are always changed into different kinds of listener. Thus, narrative medicine and narrative humility are ways to improve healthcare, creating more satisfactory relationship, and ultimately more accurate and effective treatments and diagnosis. There are simultaneously ways to deepen medical practice, bringing satisfaction and joy back to an ancient profession that is so much more than a business. Some of these ways include patient narrative, that is, the lived experience of illness as told by the patient themselves, moving beyond clinical data to the human story of suffering, resilience, and identity. The art of storytelling in this context, often formalized as narrative medicine, is the practice of honoring these stories to bridge the gap between cold medical science and the warm human experience of care. Having discussed the core principles of narrative medicine, let us now move on to understanding the techniques, applications, and benefits of this essential concept of narrative medicine. Now, techniques and approaches for narrative medicine. First, structuring the narrative. Effective medical stories often follow a classical arc. Second, the hero's journey: initiation, diagnosis, conflict, treatment, struggle, and transformation, recovery, or acceptance. Third, the five C's: character, the patient, context, their life, conflict, the illness, climax, the critical medical event, and the closer, the outcome or new perspective. In medicine, patient stories, often called illness narratives, are personal accounts of an individual's journey through health, disease, and the healthcare system. Five, unlike a standard medical history, which strictly organizes clinical facts. These stories provide thick descriptions of a patient's life, values, and psychological state. These patient stories serve as a bridge between the disease, the biological pathology, and the illness, the lived human experience of suffering. Let us talk about the benefits of narrative medicine in healthcare. For patient, it is inherently therapeutic, as being listened to can reduce stress and anxiety. Research suggests it can lead to improved glycemic control in diabetes and better outcomes for chronic conditions like asthma and rheumatoid arthritis. For healthcare provider, engaging with stories helps mitigate burnout and compassion fatigue. It strengthens professional identity and empathy, helping clinicians reconnect with their original motivation to care. Clinical efficacy, it aids in decision making by revealing a patient's personal values and barriers to care, such as cultural mistrust or past trauma. Let us discuss the important benefit of narrative medicine in detail. So, what are the clinical efficacy of narrative medicine? Clinical efficacy is the capacity of healthcare intervention, such as drug, device, procedure, to produce a desired therapeutic effect under ideal control condition, typically demonstrated through randomized control trial. It establishes whether a treatment can work, that primarily distinguishes it from effectiveness, which measures how well it works in real world practice. In healthcare, clinical efficacy refers to the maximum potential of a medical intervention, such as a drug, device, or surgery, to produce a beneficial effect under ideal and strictly controlled condition. Now, the core definition and the context of clinical efficacy is primarily established through randomized control trials, which are considered the gold standard. In these trials, variables are tightly managed to ensure that any observed improvement is directly caused by the treatment rather than external factors. What is the purpose and setting of clinical efficacy? The primary purpose of clinical efficacy is to answer the fundamental question: can this intervention work? For achieving this purpose, the standard setting of efficacy is measured in expert hand using highly selected homogeneous patient population that often exclude individuals with complex comorbidities or those likely to be non-compliant. How is clinical efficacy measured? Researchers use predefined endpoints to quantify efficacy, such as the reduction of symptoms, improved survival rates, or biological marker. Lower blood pressure. So, key statistical measures include relative risk reduction, the percentage of risk reduction attributable to the intervention compared to a control. Absolute risk reduction, the actual difference in risk between the treated group and the control group. Number needed to treat, the number of patients who need to receive the treatment for one person to experience the benefit. Importance of clinical efficacy in healthcare. Regulatory approval. Agencies like FDA and EMA require robust efficacy data before a new drug or device can be marketed. So, treatment guidelines, efficacy data from trials informs the clinical practice guidelines used by healthcare providers to make evidence-based decisions. Resource allocation, health systems use efficacy along with efficiency and effectiveness to decide which treatments are worth funding. If we talk of academic and institutional support for narrative medicine, numerous medical institutions have established formal programs and degrees. Like Columbia University, you should know about it so that you may apply if you are interested in project or any kind of a study related to medical humanities. Columbia University offers Master Degree of Science and Certification, home to the Division of Narrative Medicine. Then Lewis Carr's School of Medicine, Temple University integrate reflective writing and workshop throughout the MD curriculum. Then University of Southern California Keck School of Medicine launched a dedicated Master of Science program in 2020. Western University features the Narrative Medicine Initiative with regular narrative rounds for patient and physician. So, philosophical framework for narrative medicine talks about scholars in health humanities use various philosophical lenses to understand these interactions with narrative medicine. Herself focuses on empathetic bracketing, where a provider puts aside their own biases to experience the world from the patient's point of view. Hedger views intersubjectivity as being with others in the world of shared concern and care. Marleau-Ponty emphasizes intercorporeality, the idea that our bodies are primarily vessels through which we perceive and connect with others. Gadamer describes a fusion of horizons where different individual perspectives merge through dialogue to create a new understanding. So, practical applications talk of some of the settings or situations where these aspects can be practically applied for nursing and medicine. It is used to describe the therapeutic space where nurses and patient interact, emphasizing the importance of soft skills like active listening and empathy. Expressive art therapies in music therapy and dance intersubjectivity is experienced as rhythmic synchrony or a shared mental state created through joint creativity activity. Bioethics and suffering researchers argue that understanding a patient's suffering requires a moral witness who enters an intersubjective relationship of accompaniment and attendance with them. Psychiatry, clinical health humanities explore how pathological diagnostic labels can sometimes hinder intersubjectivity by making individuals and reducing their perceived agency as knower of their own experience. With this, I wrap up the discussion of today, that is on narrative medicine and narrative humility. We shall meet again in the next lecture with a new topic. Till then, thank you.